Good afternoon, and welcome back to part 2 of our session today. My name is James Bueller. I am the interim chair of the Department of Health Management and Policy at the Dornsife School of Public Health at Drexel University in Philadelphia, and I'm also the former health commissioner for the city of Philadelphia. Dr. Susan Choi, Senior Director for Population Health at the Healthcare Improvement Foundation in Philadelphia, will co-moderate the session and lead the discussion following our panelists' presentations. In this session, we will hear from representatives from 2 schools of public health. Dr. Neil Maniar is professor of the practice and director of the Master of Public Health in Urban Health at Beauvais College of Health Sciences at Northeastern University in Boston. Jennifer Kulker is Associate Dean for Public Health Practice and External Relations at the Dornsife School of Public Health at Drexel. In the listening sessions that the Planning Committee held in preparation for this conference, people from across the spectrum of health professions spoke of the need to more substantially address social determinants of health and principles of health equity in their training programs. For schools of public health, these are foundational concepts in our curricula. As with other health professions, we seek interprofessional training opportunities for our students and applied experiences outside the classroom. However, for our students, this involves work in communities with a variety of agencies and organizations, a focus on promoting and protecting the health of populations rather than the care of individual patients, and work with people from a broad mix of disciplines, including health-related and non-health disciplines. To the extent that our students are placed in healthcare organizations, they are in administrative, not bedside or clinical settings, and they deal with issues such as population health management, quality improvement, or performance management. What schools of public health shared with other health professions education programs were disruptions resulting from the COVID-19 pandemic, as well as new opportunities for engaging our students. Today, we'll hear from representatives of 2 schools about how they responded to those challenges and opportunities. So I'd like to invite Neil and Jennifer to make sure your cameras are on, unmute your microphones, and Neil, we'll start with your presentation.
Great, thank you, Jim, and it's a pleasure to be here this afternoon. I want to also thank you all for the opportunity to share a novel collaboration that we have here in Massachusetts, where we leveraged the energy and expertise of our academic public health community to support local health departments with COVID-19 response at a very kind of important and challenging point, early point in the pandemic. They're really kind of starting this work back in March. The next slide, please. Do I have control of the slides? Oh, yes, thank you. So I want to just start by also acknowledging my colleagues and co-leads in this work. Stacy King from the Harvard School of Public Health, Carly Levy from MCPHS, Amy Gilbert-Loines from UMass Amherst, and Tanya Blinn from the Mass Department of Public Health. And also want to give a special thanks to Stacy King for her work on designing these slides. So our Academic Public Health Volunteer Corps, it was formed as a result of a call to action from the governor, from Governor Baker and his COVID-19 Command Center. We were convened, gosh, I think it was about March 18th. It was a Friday afternoon, and he had convened, the COVID-19 Command Center had convened the leadership of the 8 accredited schools and programs of public health here in Massachusetts to find a way for us as a public health community to help local health departments, recognizing the fact that local health departments were really stretched beyond their capacity and that it was going to get much worse for them in terms of their ability to be able to respond to the pandemic. So we had this call to action. We came together, and I do want to preface this by saying that while this collaboration in terms of forming the Academic Public Health Volunteer Corps is novel, our collaboration as a public health community was not, and that was really instrumental. We had already come together with the State Department of Public Health back in 2019 to form an academic health department. So having that existing collaboration really made a difference when we came together to now figure out how we can help respond to COVID-19. Our task was to figure out how we can help local health departments. So we met that Saturday. Again, there was a small group of us, about 3 or 4 of us who met on Saturday. And by Sunday night, we had come up with the idea of forming an academic public health volunteer corps. So let's figure out a mechanism to deploy volunteers into local health departments. And in a few slides, I'll kind of show you the timeline and sort of the number of volunteers, but it was really kind of an extraordinary undertaking in the sense that we knew we had to lift this up pretty quickly. We expanded our initial group to include some additional schools, including some of the non-accredited programs of public health, as well as 3 community health worker programs that were based out of community colleges. We also worked very closely with the Massachusetts Public Health Association and the Massachusetts Health Officers Association. And MHOA in particular was our main point of contact with local health departments. Can I have the next slide, please? So here you can see our partners. So the names that are highlighted that are boldface are part of our co-leadership team. As you can see with this list of academic partners, there's a broad range in terms of both the size of the programs, the resources that programs bring, the reputation of the different schools and programs. So you have everyone from Harvard and BU and Northeastern, along with Regis and Simmons and Northern Essex Community College. And one of the things that we had all committed to at sort of the very beginning of this collaboration was that everyone is equal. Regardless of your resources, reputation, regardless of the scope that you have in terms of public health education, that we are all equal partners in terms of the voice that we're bringing to the table, in terms of the work that we're doing, and in terms of the level of engagement that our students would have in this effort. The Massachusetts Health Officers Association was as I'd mentioned, our key point of contact with local boards of health. Here in Massachusetts, we have 351 communities and 351 boards of health. We have a decentralized public health system, which sort of added to the challenge of what we were going to be able to do. And then having that existing partnership with the Mass Department of Public Health was absolutely critical to be in terms of the work that we were able to do. Can I have the next slide, please? Our mission is very simple. It is to support state and local health agencies to advance health equity in Massachusetts by engaging students, alumni, and expert volunteers through interdisciplinary collaboration. This is our goal. We really, public health, we fundamentally believe is about interdisciplinary, interprofessional collaboration, and we wanted to make sure that we brought that into the work that we're doing at the local level. There are a couple of links at the bottom where if you'd like, you can click on those links and get more information about the volunteer corps and also about our academic health department. Next slide, please. So a little bit about the structure. So we launched this academic public health volunteer corps on March 20th, which I believe was a Monday. We launched it that Monday, or actually that Wednesday we launched it, I think, officially. Within 24 hours, we had 700 volunteers sign up. Within about a week or a week and a half, we had 2,000 volunteers sign up for this volunteer corps. We knew that we would need to have a very clear operational structure, and this took some time to get to this point. But what we have now is a very clear structure where we have co-leadership of the effort. We have operational leads. We have that really manage the volunteer deployment. But then we also have different working groups around health equity, around research and evaluation. We have a number of subject matter experts really tapping into the expertise that exists within our academic health departments. Next slide, please. So we had initially started with contact tracing And that work was shifted over to the Community Tracing Collaborative. We then moved on to really providing a broad range of other public health services, and I'll give some examples of that in a minute. Next slide, please. Next slide, please. So just, I'll give you a couple, I wanted to share a few examples. Can I have the next slide, please? So part of our initial impact, and this was early in the summer, so we had, out of the 2,000 volunteers, we were able to deploy 1,200 into about 80 different communities across Massachusetts. In April alone, we made over 2,000 contact tracing calls. Over subsequent few months, over 600 wellness calls. We've translated multiple materials into a number of different languages, and we do ask our volunteers to provide language expertise. Next slide, please. So one example of what we were able to do in terms of health equity. So in Brockton and Randolph, we knew that there were some challenges identified within the Haitian and Cabo Verdean populations around testing, access, and utilization, social distancing compliance, mask wearing, a lot of stigma with positive diagnoses. So we created a team that had community members and then also heritage speakers, and really figured out how we can increase access and communication through translating materials, radio, working with local radio stations and other social media efforts to really put forth this very broad initiative to educate the community and to really educate the community in a way that responded to the cultural and linguistic requirements and needs of the community. Next slide, please. So looking about next steps, so we're going to continue our focus on health equity. We've been doing a lot of work in policy development related to reopening. As for many communities around the country right now, we're very focused on the second surge and really making sure that we help communities as they're kind of responding to an increased number of cases. We're also doing a lot of our own evaluation of this effort to continue to make sure that we're refining where we need to and really building something that will be sustained beyond COVID. We see this now as a viable and sustainable program within our academic health departments to really engage all of these different schools and programs of public health. And that is, I believe, my presentation. And please feel free to contact me if you have any questions regarding this.
Thank you very much. And just would like to remind the audience that if you have questions for Neil, to please enter those into the Q&A. Jennifer, I'll turn it over to you now.
Great. Thank you. I'm going to step back a little bit and talk a little bit more broadly about what we did as a School of Public Health and what I call the great COVID-19 pivot. Next slide, please. So just by way of background, all students in any MPH program that is accredited by the Council for Education and Public Health, CEF, our accrediting body, has to complete an applied practical experience. And it has to be a supervised, hands-on project internship. Jim alluded to this a little bit earlier, within a public health practice setting through which students demonstrate competency attainment. And if you look at, I won't read the whole thing, but the italic language is from our actual accrediting guidelines, which really stresses that these need to be external to the School of Public Health. They need to be a nonprofit or government or affiliated settings, and they really need to be public health practice. So community engagement, typically with external partners. Next slide, please. So all of our, again, Masters of Public Health students have to address and reach core competencies to get their MPH degree. And the MPH requires 22 foundational competencies in 8 general areas, as you can see on the top: evidence-based approaches, public health and systems, planning and management, policy, leadership, communication, interprofessional practice, and systems thinking. For the applied practical experience at Dornsife, we tell students that they all need to meet 3 competencies: communication, interprofessional teamwork, and systems thinking. And then they can select 2 from the other 22 competencies that are more specific to their major. So an epidemiology student might really, do a deeper dive into some kind of epidemiology program or competency. Management students may want to get more management experience. Next slide, please. And this is just an example of where our students tend to do their applied practical experiences. Again, governmental public health, government outside of public health. So we have people in our children's and families, our law department, large nonprofit public health organizations, some clinical settings, but again, as what was said, not at the bedside, really things like strategic planning, quality improvement, population health, and some regional planning associations. And then the types of products and projects that they do, needs assessment, strategic planning. The accrediting body not only requires the competency mapping, but students have to complete 2 discrete deliverables for their site that they work with that are assessed by a faculty member. So that's one of the requirements of the applied practical experience. Next slide, please. So the 2020 pivot, what do we do? So most students complete their applied practical experience in the spring or in the summer between their first and second years. And so COVID hit really during the peak time where we were reaching out to sites and working with students to find placements. Like everybody else, I think we thought, okay, we got a couple weeks, we got to regroup a little bit and we'll be back to business by, April 1 or April 15th. And quickly we realized that that was not going to be the case. So we realized that we really needed to change our approach to the APE for 2020. And we tried to frame it for ourselves in terms of 2 key questions. How do we make the student applied practical experience as rich and rewarding as possible? So for the student to make sure it's valuable. And then how do we best serve our public health community? Because certainly our public health partners and community were facing a challenge that they had never, ever seen before. Next slide. So what did we need to do? And we really, I think I divided this into sort of four overarching things that we needed to do. The first is we had to reassure students that they would not miss out on this critical component of their MPH training. Students come in really looking at their applied practical experience as key to them getting the training they need to get a job when they get out. So students were anxious overall about everything related to COVID and particularly concerned about missing out on this. Many students really wanted to do something COVID related because here they are studying public health and there's a pandemic and they want to get right in there and do it. And many of our students were dealing with their own issues, family members with health challenges, with COVID, isolation, quarantine. I've said all along that graduate students are in a tricky spot, I think, because many of them, they're too young to just go back home and live with mom and dad as my college age kid was able to do. But they mostly live alone. They had their own issues of isolation and fear. So we really needed to reassure them that this piece of their training would be okay. Then we also had to strategize with their external partners to identify and redefine opportunities. So a lot of the existing projects that our partners had put into our partnership and applied practical experience database got canceled. And they got changed because they could no longer think about doing, a nutrition needs assessment for their clients when they were faced with a pandemic. Organizations themselves were struggling to manage the shift to remote work for their own staff, so couldn't really imagine how they would then take on the supervision and mentoring of students. And organizations were overwhelmed, and this is especially true for our Philadelphia, our local health department, but all of our organizations were just overwhelmed with trying to figure out what to do. And so the idea of having students in the mix was difficult for many. So we really had to take time to work with them to redefine and rethink how could students really be of value to them in this time, even under the current COVID situation. Next slide, please. And then we had to ask our accrediting body, for greater flexibility in APE requirements, because as I said, the requirements are pretty specific in terms of where they can do placements, competency mapping, and deliverables. So to do this, the Association of Schools and Programs in Public Health has a practice section, and it's where associate deans and people in charge of the practical experience tend to sit. And we came together very quickly and drafted a letter very quickly, a letter written by about 40 people that I spearheaded, asking for flexibility with APE requirements, including things like the content of the experiences, so students would have the opportunity to do more kind of volunteer service type work, similar to what Neil had been talking about earlier. Types of deliverables, that we have flexibility on that. Preceptor requirements, that was a big one because CEIF usually requires preceptors to have public health experience and it be a really hands-on mentored experience. And we wanted to give the option for more faculty mentoring or supervision if we needed to. And then the competency matching. And this is just a quick excerpt from the letter, which is we said, we aim to make the APE requirement as enriching as possible and provide opportunity to strengthen our students' commitment to and experience in public health. We are confident that as individual schools and programs, we can assure and manage the learning that will come from these experiences in ways that both meet our students' learning needs and achieves the intent of the APE. So basically what we said to our accrediting body is trust us, we got this, don't get in our way. And they obliged easily. It was not a fight. They were actually able to do that. And then the final thing we did was we had to develop some options for our students beyond the traditional one-to-one placements, recognizing that there might not be enough demand for the supply of students. So we developed our own internal consulting course where we solicited some case statements and problems, had the engagement from some of our external partners, but not as intensive an engagement as if they were hosting a student. And we were able to have a course last summer that students were able to opt into. Next slide, please. So how do we do? All of our students got covered. They all got placed. They did a traditional, the remote placement, or one of the other options. We heard from our partner organizations that they really valued us taking the time to work with them to get these placements going, and that our students really made valuable contributions. Students really missed, like all of us, the experience of physically being in an organization, and they missed out on those soft skills and the nuanced learning that you get just by working in a place with other people. Mentoring and supervision was a challenge in a remote setting. The course and the team-based options, in addition to just being sort of a safety net for students, they were also enabled a less isolating experience. So going back to my first point, for students who are really struggling with kind of being cut off, that was actually a nice experience for many of those students. And I think we proved to ourselves the ability to think and move quickly and respond to a challenging and changing situation, which sometimes in higher ed we think we can't do, and now we can do. So just my last slide, 2 final points. So the thoughts for the future. As Jim started out the session, in public health, we think of interprofessional education far beyond the clinical and healthcare setting. We work with law and social services and education. We need to continue to expand our thinking to multiple sectors. And this COVID-19 has really driven that home. An example that I've used over time is if public health is going to make decisions about whether schools or businesses are open, our students and our trainees need to know about how these sectors are organized, how they're built, how they're staffed, how they're financed. And we've seen time and time again how people are making decisions about school opening and closure without having any idea how many desks sit in a classroom. And we need to have that shared knowledge. And then finally, how can we truly be responsive to our public health partners, especially during a crisis, and whether or not our competencies accurately reflect public health practice, and whether or not our accrediting body can continue to be flexible with requirements, and how can we continue to be flexible and nimble. Thank you.
Great. Well, thank you so much, Jen and Neil. I've been told we have about 4 minutes for questions. And so just wanted to start with a question that was put in the Q&A for Neil, and specifically around the reason for targeting the Haitian population and the example that you shared.
So all of our work at the local level is in response to needs that the community identifies. So we, through the MHOA, we're continually surveying local boards of health. We also have teams in place in many communities. So through the work of those volunteer teams, we were able to identify additional areas of need. So with this project that came about in Brockton and Randolph, that was something where we had heard from the local boards of health and the local public health leadership that they really wanted to figure out a way to address this. Those 2 communities, we were able to find within the Haitian and Cape Verdean population sort of these needs of kind of addressing some of these issues through materials that were translated into different languages. So I think one of the things that has really made this effort so successful is that we have this conduit to really hear from local boards of health and respond rapidly to what they need. And this was one example where we were able to do that.
Great. Well, thank you so much, Neil, for that response. And just wanting to encourage any of the audience members to put any questions in the chat. And kind of in the meantime, just wanting to maybe throw a quick question to Jen. And you kind of ended with like, how do we do? And so it's a question of like, how do we evaluate the success of these pivots? And so just any thoughts about that? And a question, I'll be throwing that to you as well.
Sure. I mean, I think, the short-term success is we had X number of students and they have to do this experience and they all did it. Mm-hmm. And they all had their things assessed by their faculty members, and they all did that. So that's on the sort of checking things off, that's the piece. and our students came back. So I think there was just really a fear, of retention and losing students, because I think our students really, we talked about trauma in the early session, just struggling. And so the fact that students had experiences that kept them tethered to the school and to public health was really, was a measure. We're in the process of we do evaluation with our preceptors every year about students and their contributions and their deliverables. That's taken on a different life this year because our organizations are so overwhelmed that taking time to really think about that. But that's an ongoing, I think we're going to have to look back, especially as we gear up for next summer, because we don't know what next summer is going to look like.
Yeah, no, absolutely. Well, thank you so much for that.
Sure.
And I think we have time. And actually, Neil, I think you're off the hook because we have time for maybe one more question that just popped in. And I think either one of you could take it, which is any consideration to include colleges of pharmacy in the discussion, especially as we're talking about, kind of interdisciplinary, interprofessional work.
I'm happy to start with that. So one thing that I didn't mention earlier, so we're actually currently expanding our focus to include other health professions across sort of all the different academic partnerships that we have. So for example, here at Northeastern, I'm reaching out to our School of Pharmacy, School of Nursing, our physician assistant program. Other colleagues are reaching out to their medical schools, schools of social work, to really make sure that we build out the interprofessional piece. We are, with the vaccines on the horizon in particular, there's a real opportunity to partner with our colleagues in the School of Pharmacy, both importantly to help provide information to communities, to educate them about the vaccine, to answer questions. There are a lot of questions, there are a lot of concerns that folks have, and to really help us with that.
Great. Well, thank you, Neil. And we are getting the hook, so I'm going to actually pass this over to Dr. Kim Lomas for the next section of this session.
Great, thank you, Susan. Wonderful insights in that section of our discussion. I'm Kim Lomas. I'm the Vice President for Undergraduate Medical Education Innovations at the American Medical Association. And we're going to speak a little bit about the clinical learning environment. Of course, experiences in the clinical learning environment are a critical element across all health professions education to support the development both of competency, but also professional identity formation. And in March, learners across our professions were really abruptly displaced from care settings. And this was due to both safety and educational concerns. From a safety standpoint, the concerns about the safety of the students, the safety of patients, given limited bandwidth of faculty to appropriately supervise clinical students, but also educationally with the disruption of case mix and the way hospitals were functioning or other clinical settings were functioning. Perhaps we weren't getting the right kinds of patients that students needed to advance their education. So we'd like to reflect on some innovations in clinical education that have positioned us to interact this summer and try to regain some clinical experiences, but will also help us as we face ongoing disruptions in this environment with continued surges across the country. As we speak, please share your experiences, what you've done to maintain activity in the clinical learning environment for your learners in the Q&A. Doesn't have to just be questions. We'd love to see your tips and ideas as well. So I'd like to introduce my colleague to kick us off. Nancy Spector is PhD and RN, as well as Fellow of the American Academy of Nursing and Director of Regulatory Innovations at the National Council of State Boards of Nursing. Nancy, can you share with us what your organization has been doing to ensure adequate clinical experience for your learners?
Sure. Thank you, Kim. And, I'm going to tell you about a collaborative solution that nursing leaders came up with. It was really not just NCSBN. It was leaders coming together when their students or our students were shut out of the practice settings. And, as Kim said, this happened back in March. It's still happening today. And this is the Practice Academic Partnership. Next slide, please. So the background, as you know, COVID-19 has put a significant demand on our nursing workforce, and therefore we really needed our students to graduate and be prepared. And yet around the country back in March, practice settings were shutting their doors to students and calling them visitors, and preventing graduations. And we were possibly graduating students who were underprepared because they didn't have enough clinical experience. you know, while simulation and virtual simulation are effective, nothing can replace those clinical experiences with patients. And one of the students who was in one of these programs said it well when she said, the students can only get so much out of, you know, doing a lab or a simulation experience. One board of nursing actually worried that some students would graduate without even having touched a patient. So next slide, please. So in March, nursing leaders from practice, academia, and regulation, and regulation because they have that whole state pulse on what's going on, and they can help disseminate initiatives such as this, which they did, came together virtually, of course, to come up with a solution, and collaboratively, they developed the Practice Academic Partnership. And, you know, this is kind of loosely defined as leaders in practice and education working together to advance the education of nurses to improve the health of patients, communities, and populations. And, you know, a lot of these have taken place in hospitals, but when we say communities, many of these partnerships have taken place in communities where students have been out doing contact tracing or COVID-19 testing. Next slide, please. So what about the program? The key to the program is that students are essential workers. Now, this is, you know, from the perspective of both the healthcare setting and the university or college of nursing, but there may need to be communication as well with government, the governor's office, and this has been done. In our experiences, they almost always agree. And the Practice Partnership really incorporates all levels of pre-licensure nursing education, and the students can be employed and still receive academic credit, but they don't have to be employed because we want to serve as many students as we can. And the faculty always provide oversight over the students, though in some cases, practice may provide preceptors. This isn't absolutely required, but they may. But even in those cases, faculty provide oversight over what's happening. Then academic credit is awarded toward clinical experiences. So it's really that win-win situation. Next slide, please. So what about the benefits? This is really an unparalleled opportunity for students to work and learn in a time of crisis. The principles of health, population health, and emergency management are made clear to them firsthand, even if they're not working with these patients. They see it going on around them. And of course, it allows their students to meet their clinical requirements, which is so essential in nursing. Next slide, please. Now, the key organizations in nursing came together, participated in writing this model, and have all endorsed it and are disseminating it as we speak because this crisis is still going on, as you know. Next slide, please. As you might imagine, for lessons learned, communication is essential. Established relationships can be pursued for this, but also new relationships can be created. And we found this very interesting that the critical access hospitals stepped up to this, and they hadn't always had students in the past, but they were very open to this. And there was a comment on the chat about home health nursing. This would be a perfect solution in home health nursing. And I do, you know, I will plan to let our faculty know about that because maybe they haven't thought about that. Expectations on both sides should be discussed. For example, oversight of the students. Is it the faculty or is it the students? Now in nursing, boards of nursing approve programs. So of course the programs need to make sure that they're meeting the board of nursing requirements in this model and the accreditation requirements as well, but they should be. Next slide, please. So for practice involvement, as I said, the rural hospitals were eager to join, and that really kind of surprised us. We thought it would mostly be the medical centers. Many of the schools already had practice agreements with some practice settings, so they built on those. But those that needed to prepare them, some have asked if we have like contract templates. And, you know, as you know, with doing contracts, that can vary because of our lawyers. But there is an article coming out in the Journal of Professional Nursing that highlights the principles of the practice academic partnership that could be used in one of these contracts. And I believe that's coming out at the end of November. The COVID-19 policies should definitely be made available to the students, and certainly provision of PPE needs to be determined in many of these partnerships. And we're doing some impact studies now on what the impact has been on nursing students, and we're finding that many of the nursing programs are providing the PPE. And of course, the experience needs to be planned with practice and the nursing faculty. Next slide, please. So for faculty involvement, as always, faculty would be developing the objectives, evaluating their students. They would collaborate with the practice settings to identify the experiences that would meet their requirements. And faculty, yeah, I think I saw this in the chat too about faculty being more flexible than usual with student absences. For example, you know, not encouraging students to come in with minor cold-like symptoms and the like. Next slide, please. Students also must know the expectations of this experience. It's very important for them to know the settings policy of COVID-19, and they really need to complete courses on donning and doffing PPE and general COVID-19 care of patients. Now at NCSBN, we do offer free courses on that, and those would certainly be useful for this. Students must also know the risks and responsibilities in taking part in these. Their personal responsibility of hand washing, for example, not going to parties where they could be exposed, those kinds of things. Next slide, please. So what about the clinical assignments? The students generally take care of non-COVID-19 patients, we've found, freeing up the nurses to care for the COVID-19 patients and more serious patients. However, some later in their program have worked with the COVID-19 patients and have found it very rewarding. Also, some of them have participated in giving flu vaccines, and maybe down the line they will with COVID-19 vaccines, screening, contact tracing, and testing. Next slide, please. So everybody always asks about evaluation. Next slide, please. We suggest that you survey the students, faculty, and the healthcare setting about the experiences. As far as I know, there are no surveys out there that are available for this, but we could look into that at NCSBN. Some of the boards of nursing may ask for updates, though usually they're mostly interested in how many students have participated. Next slide, please. Another big question is always about outcomes. So we did interview some of our participants. And for example, one of our students said, it's actually a pretty challenging, but a very rewarding experience. Faculty, our students embrace this opportunity to help meet the needs of the community during this unprecedented time. And then the practice partners were very enthused about it. It's a great program. We hired 92% of the spring graduates. Of course, that can't always be done if you're not a big medical center. And 100% of the graduates passed NCLEX. So here are some of the numbers of students participating in the program. In Idaho, for example, it's being implemented across the state, and this is facilitated by the Board of Nursing there, and they've had 385 participants. In Iowa, it's also being implemented statewide, and there have been 125 students for the Kirkwood Community College and 129 students from the University of Iowa. And then Emory University in Atlanta is implementing it. And there have been 90 students that have gone through this. So next slide, please. Last slide. So really the Practice Academic Partnership is a great opportunity for the future of nursing, for doing things a little bit differently. And, you know, David Daniel was talking about measuring around your target. I was thinking about this with this policy. If, you know, we were just looking at the target as being getting students clinical placements during COVID-19, but there's also been a lot in nursing about the practice education gap. This may help with that as well. So on the upper right, this is our website. On the upper right is a link to some of our resources for helping to implement this Practice Academic Partnership. So thank you very much.
Thank you, Nancy, for sharing those insights and that experience. I was really struck by your comment about the status of students. Are they actually visitors in our system who are dismissed at times of strain, or are they talented and dedicated potential extenders of our workforce in a time of crisis? So we'd love for participants to put your thoughts about that in the chat, because I think that's a really critical point for us moving forward. All right, in the interest of time, we'll jump into our next presentation. Hopefully we'll do some questions afterwards. Nancy, thank you. I'm going to speak on behalf of our pre-existing consortium, the Accelerating Change in Medical Education Consortium that the AMA launched in 2013. And the idea that a baseline investment in innovation positions us better to respond in times of crisis. Hannah, if you could advance the slide, that'd be great. So we do have a community of innovation that exists of 37 medical schools and multiple graduate medical education programs that have been working together. And fortunately, a big emphasis of our group has been around the training of health professionals in health system science. So we already had a group of systems thinkers, as was brought out earlier by Pinar. It's really important in times like this to be able to bring that systems lens. So we were fortunate to learn from that community. Hannah, if you could advance, that'd be great. So everyone has suffered significant disruption. Most of our learners have very carefully laid out plans for their education and hopes and aspiration. And most of our curricula have relatively rigid structures. And so in a time of disruption like this, we need to use systems thinking to step back and think about, are there alternate paths to the same outcomes that we had hoped to achieve? Next slide. So we were able to convene our consortium members virtually on a regular basis throughout the early parts of the pandemic to hear what they were struggling with, what ideas they had, and they really benefited from sharing with each other in the moment to come up with strategies. So I'm going to share more of a framework rather than specific solutions. What we saw initially was many schools just converted to bridging didactics as students were pulled out of the clinical environment in order to train them around what was happening in COVID, but also buy some time, honestly, to create alternative pathways. The next phase we see is engaging students in patient care roles, but those that are physically distanced. And as has been brought up several times in this webinar today, this really, we have to give a nod to the leadership of our students. When we talk about professional identity formation, there was nothing more fulfilling than seeing students step up and say, we don't want to be sidelined. We want to find ways that we can add value to the process that's going on. And so various roles that were remote, such as helping patients prepare for telemedicine visits, managing hotlines, creating educational materials. Much of that idea, the ideas for these things came by students, and then work with the educators to vet them and understand how that furthered their development. Then ultimately, of course, we need to get back into direct interaction with patients. Many sites were able to accomplish that safely this summer, but as I said before, we're facing surges again. And so understanding what are the criteria by which a learner should or should not be in that space is important for our planning moving forward. Next slide, please. So what we found useful in our consortium was to look at what we considered to be clinical experiences of history what our vision is of a given course, such as a clerkship in internal medicine for our medical students, and do some deconstructing using competency-based approaches. And so in a competency-based framework, you start with what are the desired learning outcomes. And then from that drives the kinds of learning activities that are necessary, as well as the types of assessments that are necessary to ensure the specific competency is really being probed. This seems logical and intuitive, but I think if many educators are honest with themselves, we tend to be a little bit entrenched in historical learning activities, and sometimes we lose sight of the real outcomes that were desired. So again, this notion of let's step back, deconstruct it, look back at those outcomes, and are there new learning activities that could get us to the same place? And you'll note in this framework that time, which we have traditionally used as a proxy of an outcome of learning, this course should be 6 weeks long, time becomes more of a resource for learning. And so we've lost some of that resource. We have to think about how to use it more effectively. And can we use time in other settings to balance some of the competency needs until we can get back into the direct clinical care setting. Next slide. So when we look at an example like a clerkship for medical students, we went through this process of thinking of the layers of competency development that were taking place. And that then allows us to think about alternative means. And so at the base, we refer to the big C competencies. For us in undergraduate medical education, many of our schools align with the expectations of graduate medical education, which are these domains that you can see here on the slide. And when you step back and think about those domains, you don't have to be in direct physical contact with a patient to work on your interpersonal and communication skills. Helping a patient, an elderly patient, prepare for a telehealth visit and navigating that space, answering their questions can be a great experience in developing one's interpersonal and communication skills. So those kinds of competencies are an expected and embedded outcome of many of the traditional experiences we have. We can tease those out. Similarly, overarching clinical skills like clinical reasoning and diagnostic skills could be met through remote means and other ways. So what you'll find then is that for the precious time that remains in direct physical contact, we can concentrate our efforts around the things that are really specifically necessary to accomplish in that setting. Next slide. Similarly, most of us have lists of the types of patients we would hope that students encounter. And that's usually very helpful as they go through their clinical experiences to make sure that they're seeing the right diversity of clinical exposure. But even those encounters have multiple reasons for them. So I'm a surgeon by training, used to run our surgery clerkship. And of course, in surgery, people expect students to be exposed to appendicitis. Is it really specifically that they need to understand all the nuances of appendicitis, regardless of what field they're going into? Or are there other elements that are important, such as general approach to the acute abdomen? And so teasing again apart the reasons why we have those types of patients on the list, we might be able to envision alternative mechanisms to reach that goal. Next slide. So this kind of competency-based framework can be particularly helpful in a time like this. Our students are incredibly strained, the faculty are very strained, everyone is having to make changes on the fly. As David Daniel was talking about earlier, we're trying to respond as quickly as we can. We need time to see what does and does not work. But using this kind of framework, the deconstruction and the outcomes-based approach allows you to have a stronger rationale for why you're doing something differently. And so at least on the front end, it shows the reflection and thought that went into the decision for an alternative pathway. So this helps the learners better understand that this disrupted education is still adding value to me. And as mentioned before, they are our colleagues in this process because they can often help us co-produce these kind of alternatives. And I think an important piece of this as we make these changes is to be very mindful of the diversity of our learners' experience. And so any cohort of students is not uniform. Even among them, there's a variety of types of experiences that they're going through. And this competency-based framework helps us really hone in on what is most critical across the board. Next slide. So finally, we have to admit that these students will have gaps in their experiences. There's no getting around that. And the challenge for us is that the gaps are individualized. What students were disrupted in doing varies among them. And so as they move forward, either in additional training or entering even into practice, a competency-based framework accepts that. It says, okay, that's fine. We just need to follow up with that and fill those gaps over time with additional experience and training. And in the meantime, whatever oversight is necessary to maintain safety. Next slide. So we did benefit from our consortium, our partners. I want to acknowledge again the efforts of our faculty participants across the country, as well as their students and residents who participate in our work. We do have many resources available from that group that are open access and there for your review. So you can take off the slides. Do we have a moment for a question? I think is ask our moderators. Okay.
Yes, we do have time for a question if you have one.
Okay. Trying to grab here really quickly in the Q&A. So I think, you know, Nancy, we both were talking about how to create these alternative experiences, and people talk about the challenges of numbers and making sure everybody gets placed. And that was one big accomplishment, is that everybody got placed. Do you want to briefly comment on that?
You know, I think I just answered somebody privately about that. I think really what it comes down to is having a faculty member over maybe more of students and then a preceptor at each place. And, you know, some said, how do you get into these places? It really just takes asking to do it. And you know, as you said, they really are essential workers. There are a lot nursing students or medical students can do to help. And providing them with that background. And like, we were so surprised about critical access hospitals. They just loved the idea. And we really hadn't had that experience with them before. So I think that's really what it's about.
Well, that's a great segue because our students are amazing and talented and dedicated, and we're about to hear from some. So Amelia, do you want to kick it off for the next section?
Yes, thank you so much. Hi, everyone. I have the slides. My name is Amelia Iwu. I'm assistant professor at Rutgers University School of Nursing. In this segment, I am going to be working with some of the students who will give us some feedback on what they have been doing to survive, what we've put them through, and COVID has put us through. So as we get into this section, additional information about myself is also I'm directing our Office of Global Health. So I come to this group with some global experience as well, and know what some of those challenges bring to the table as we do what we are doing. So we'll be hearing from 3 students. Next slide. Those students are Londyn Robinson, a medical student from University of Minnesota. Our second speaker would be Angela Wilbon. She is a PhD social work student from Harvard University. And our last student is Jusna Hook. Jusna is a nursing student at Rutgers University in Newark, New Jersey. So I would like to pass the baton to Londyn. However, we asked them to speak to us about the following issues. They will briefly introduce themselves and then describe their own experiences or their peers' experiences since they're representing a group, and then let us know how they have coped and so adapted to what went on since COVID-19. We are hoping that from their discussions, we will get some information about positive experiences they've had, as well as negative experiences, and some recommendations in terms of what they will want us to keep or improve upon, or what they really want us not to continue to do. So thank you so much. I want to say thank you to the students for their time today. Londyn, can you let us know your experiences. Next slide. Next slide, please. Thank you.
Hi, thank you. My name is Londyn Robinson. I am a medical student, a fourth-year student at the University of Minnesota Medical School, and I'm currently very excited to report I'm applying for internal medicine residency and hope to become a rheumatologist someday. I listed some things that I'm passionate about there, but what I really want to talk to you today is as a representative of medical students, which I've really appreciated hearing about all the innovations that have took place from the faculty level. I really wanted to talk about how we transitioned from our clinical rotations to this virtual environment and if many of us feel prepared for residency. So for example, of the last 9 months, most medical students at my school have had in-person clinical rotations for only 2 to 3 months of our entire senior year of medical school. And so I just want to ask an inquisitive question of, are we prepared for residency? And to be quite blunt, some students have our doubts. Next slide, please. Prior to getting into more of that detail, I wanted to share with you something that we did that was pretty exciting at the University of Minnesota, which was a group of medical students co-founded a nonprofit company called Minnesota COVID Sitters. We recognized right away in Minneapolis, just like across the entire country, that childcare is one of the major bottlenecks that prevents healthcare workers from getting to work. And especially amid COVID with school closures and over 95% of students siloed into their own homes, healthcare workers were then caught choosing between going to work to help care for people's families or staying at home to care for their own. So we worked with a local technology company to develop an application that used GPS coordinates to match healthcare workers in need with free babysitting services. It kind of ended up taking off and it mushroomed into sister branches that formed in 32 states and 5 separate countries. And we have over 1,000 families served and 3,000 volunteers. We learned a lot of lessons from this, mainly that medical students, interprofessional students, social work students, nursing students, we can really use technology to address societal needs, even without oversight. This was completely student-led. There was no attendings telling us what to do. It was our own idea, and we did it in our free time outside of courses. In this, we integrated public health response into our graduate curriculum. But I really wanted to point out something, which is that students are not free labor, and we're still learners. And many of us are doing this outside of our coursework time. And as I have listed, we focus on interprofessionalism with COVID sitters. Next slide. Very grateful to the National Academy for publishing the commentary piece about Minnesota COVID sitters. And if you would like to learn more about it, please feel free to read that article or just Google MN COVID sitters. Next slide. So then back to my kind of hat as a medical student. When there was kind of some positive things that I talked to my friends about in medical school, and then some challenges that we observed within the med school sector. So first to the positives. Very thankful to report that there seemed to be some fairly seamless transition to online coursework. Aside from what it sounded like was the conundrum going on in a lot of faculty members' heads, we didn't feel that as students, at least here. And one of the other things that we really appreciated was that companies and conferences offered some free open platform resources to us, and that the online format has increased student participation and engagement. There were some serious challenges though. First and foremost, as Dr. Spector commented for nursing students, you can't replace the in-person clinical environment, full stop. Like it just cannot be replaced virtually. And so this gets back to the question of residency preparedness. Do we feel prepared graduating a cohort of medical students, 25,000 of us, that are now spending 2 months of our in-person rotations of the last 9 months of our 4th year of residency? Another thing that I would like to mention is that some schools continue to sweat the small stuff, particularly in 1st and 2nd year medical school curriculum, in that they're doing equal, if not more, virtual work than they were before the pandemic. And then finally, I wanted to point out that all of our state and local levels have detailed public health initiatives that include staying at home. And as students, we are instructed to stay at home. But that then was the only exception to that was to take our MCAT exams and our medical licensing exams. And the hypocrisy that is sent to students when we are forced to take in-person exams that create chaos. And just to close, I just wanted to share that I rescheduled my USMLE Step 2 CK exam in 6 separate states, and I rescheduled it 5 times in 6 separate states, and ended up taking it on the day of my grandmother's funeral, on top of doing COVID sitters and my virtual coursework. And I'm not alone in some of those challenges. So with that, I'm gonna pass it along to the next student, Angela Wilbon. She's a student of social work. Thank you.
Thank you, Londyn. Angela, you're on.
Awesome, thank you. Well, good afternoon, everyone. Like it's been said already, I am a PhD social work student. I am in the dissertation proposal writing phase, and I listed my topic there. And there are things that I am passionate about. And one thing for certain is empowering humanity to be its best self, starting with myself. And my fellow students also weighed in. And I want to also point out that I have a dual role as a student and also a trainer of MSW students, where we have a HRSA grant where we're training students to be behavioral health providers. And so I play a role in developing our students. So I'm coming in this conversation in that as a dual role. And when I talk to students about, well, what are some of your experiences of how you're coping and adapting to the pandemic as students? And so in looking at it, it's students fulfilling their academic requirements while also taking care of themselves and their families and the things that are coming up inside this pandemic, while also providing client care. And so students, myself included, experiencing isolation during the dissertation writing phase or in process of coursework. And we created various Zoom writing groups or academic groups or study groups to be able to deal with some of the isolation. And students worked on and have been working on, how do you master empathy and building rapport and connection virtually? Or if you do have the opportunity as a student to be on site, how do you do that while social distancing? And so students were grappling with that and continue to grapple with, how do you do that? How do I do that? And how do we train students to be able to do that? And also when it comes to coping and adaptation, it's authentically acknowledging the victories and challenges, the transparency about what students are faced with, what we're dealing with, and increasing self-care, things like gratitude inventory, breathing exercises, exercising in general, meditation, virtual social events and activities to connect with other students and other people in their lives. And then granting grace and compassion to others and self, and practicing that moment to moment, because there's what we expect that we should be doing as students and what we should be doing as service providers, learning to be service providers. And then there's granting grace with the gap. Next slide, please. And I won't go over all of these, but I will highlight some in particular about positive educational experiences. And one of the things that students have talked about, myself again included, is the faculty encouragement and support, whether that's Zoom or email or telephone calls. Really, students really feeling like the faculty were there supporting students as they're going through not just the academic journey, but also the personal experiences. We've had multiple students who've lost family members or friends during the pandemic, and students are really saying that they felt faculty and staff support in that journey. Another thing that students are saying works is interactive, experiential, and problem-based student-centered learning, where students can be engaged and pulled into the lectures and the conversations such that they are owning that experience and that education. And also, when we looked at students, we had the opportunity to partner with our case simulation center that we have on Howard campus, and students had the opportunity to participate in standardized patient case telesimulation. And they rave about it, they love it. I enjoy it myself as far as another way that students have the opportunity to hone their craft as service providers. And we continue to learn as students, but also training students to what are the best practices and ethical elements of telehealth services. So honing in and talking to students about those best practices, but also the ethical responsibilities as service providers. Because students talked about how nervous they were about engaging with clients over Zoom. And then we continue with interprofessional education and training opportunities. Next slide, please. Closing the gaps, I'm going to highlight a few things, and that is we had less field placement opportunities as students. And another thing that needs to be looked at is improved student health insurance, so students can have access to quality mental health services. And lastly, to increase strategies to reach and serve medically underserved communities who lack technology. Thank you.
Thank you so much, Angela. Very thoughtful issues. We're going to go to Jusna. Jusna is a nursing student from Rutgers. Actually, after last semester, she decided, she made some observations that made her try to go into a minor, and I'll let her talk about that about herself. You're on, Jusna. You can open your mic and talk, and your camera.
Oh, I apologize about that.
Okay.
Hi, everyone. My name is Jusna, and I'm currently a junior at the Rutgers School of Nursing in the traditional baccalaureate program. And I'm also an EOF student, which stands for Educational Opportunity Fund. So this is a state-funded program to provide academic support and counseling to students from disadvantaged backgrounds, but do meet the academic criteria and standard. So some of the things that I'm passionate about is financial disparities that lead to healthcare disadvantages and the importance of nursing education. And this is one of the reasons why I currently decided to minor in sociology as well, just to learn more about these concepts, because during COVID, we did see that how certain areas were impacted more from COVID than others. Next slide, please. So right now I'm just going to talk about my experience, how the virus affected my peer members' junior year. So junior year of nursing school is predominantly the hardest part of nursing school, because this is when we are taking our fundamental classes that later shape us as a nurse. So during this semester, prior to March, I want to say everything was normal. Like our routine was very normal. We went to clinical as instructed. We only wore masks when we came across patients that had specific illnesses, such as airborne or droplet precautions. However, during mid-March, suddenly the news of taking this pandemic seriously came out. Suddenly, the lecture classes were canceled and moved to online with very short notice for us. Students and professors both had to adjust to this new realm. In fact, for my class, I remember having a pediatric exam the very next day, and the night of, I was told by an email from Rutgers University that not to come in the next morning to school. So we were very confused, like, are we taking the exam? Are we not? And how is it being adjusted to online? Clinicals were also stopped at that time due to the shortage of masks and personal protective equipment, and that was a safety concern for all, including students. And along with school stress, we also experienced hardships at home, because we had family stress as well. Like many of our families were diagnosed with the virus and did have symptoms. And so all of this was going on while we were still expected to meet the hard curriculum of nursing school during a national pandemic. However, there were some positives throughout all of this, and some of that, personally for me, since I'm a commuter student, it saved money, and I saved money on gas and parking meters by not driving to school. Since everything was online, it also saved time. And during these hard times, it created stronger bonds between my peers and I, and between family members as well. And many students also experience individual growth to know our own strengths and weaknesses as well. Next slide, please. So here I highlight some of the negatives that posed as challenges. So the sudden change of learning from in person to was hard to adjust to, especially for nursing students because we do focus more in classroom settings, and also we were missing a lot of our hands-on learning experiences because nursing lab work is best understood when in the simulation lab rather than online. Many of us also struggled at home because again studying test taking and studying became a hard struggle at home because many of us lived in environments or apartments that were small. We live with many other siblings and children in the house, so it was hard to get that quiet study space. We were caring for families who experienced symptoms, and personally for me, I also experienced family members losing life due to COVID. And all while we were still expected to continue on with the high expectations of nursing school. And by that, I mean, we were still expected to pass the designated grade point average of nursing school to successfully continue on, while most of the other majors were given a pass or fail option to make their grading criteria much easier. To kind of cope with this, I wrote up some coping strategies that students needed to find in order to deal with this kind of stress. And that was, we found peer-to-peer support, and we acknowledged our emotions rather than suppressing it. And I wrote this because since I'm in the traditional baccalaureate program, some of the students here are as young as 17 years old and as old as only 22 years old when we graduate. So we needed to find support systems within ourselves to kind of understand how we were feeling. So I want to close this up with hopes for the future. So I spoke to many of my peer members and we all agreed with this. And there's a saying that goes that nurses eat their youngs. So that's why I decided to put this part in. So since many students did not get the full lecture, clinical, and lab work experience in person, we as students hope that experienced healthcare staff can take the consequences of this pandemic into consideration and help us during the many struggles we may encounter on the units. That's it. That's how I would like to.
So much, Jusna. Thank you. Now we're going to do some interaction. As you guys spoke about your experiences, one of the overarching concept I got from you is that you are very worried about clinical experience, getting the hands-on experience in order to be able to assure yourself that you're confident in your skill to care for patients when you come out as clinicians. So I'm going to start with Londyn. As a medical student, you're applying for residency. It kind of came out in your presentation, and now Jusna just mentioned the fact that, okay, so how are we going to take care of you knowing that you didn't get this hands-on? Can you tell us more about what students are worried about from that angle?
Yeah, I think first and foremost, we want to be good clinicians, we want to be good physicians, we want to be good nurses, and we want to be good social workers. And part of the entire model, as Dr. Spector brought up earlier, was that there's this very concrete mechanism in place for medical education across all different specialties, and that was totally blown up amid COVID. And so now we don't really know what we don't know, but what we do know is that we haven't had the traditional patient care experiences. Yeah. And so my main concern and question to all the educators here is, how will residency programs, how will advanced practice nursing programs, how will people that are hired in social work adapt to the lack of knowledge that we might have gotten amid our MS4 curriculum, amid our senior year in nursing curriculum, et cetera? And what kind of competency changes need to be made in order to ensure that we can provide competent patient care to, and not only that, but then also get the same learning that we deserve like all of our other classmates.
Absolutely. Very good point. So I'm going to go to Jusna. Jusna, some of our students attend classes from homes with families in communities already severely affected by COVID-19 and many other social and health disparities. What are these students most worried about right now? What do you think that, if they were to be in this room today talking to educators and policymakers about their training, what do you think they would want us to bear in mind? Jusna.
So I have spoken to many of my peer members regarding to this. And based on what I've heard from the feedback, many of the students right now do feel fortunate that Rutgers University is one of the few nursing school in an institution that was able to continue on with clinical during this past semester at very well-known hospitals. during the fall semester. Students are grateful for that. However, since many of us do come from social disparities and unprivileged backgrounds, and we may live in households with many other people, such as elderly grandparents and children, and parents who may have other comorbidities, sometimes there is a fear of being exposed to the virus at the hospital and bringing it home, and that may affect our loved ones. And however, students did say that they are taking personal protective equipment very seriously when it comes to that, and they're trying to stay safe as well as getting the most experience at clinical.
Thank you for sharing that. Angela, social workers are very critical to what is going on in our society today, actually globally today. I know you mentioned that a lot of the clinical settings in the community, some of your students will be posted to agencies that are working with underserved population. You mentioned the fact that you are afraid that we're not serving people who don't have phones, people who don't have computers. So what are you thinking? We want to hear more about that. What do you want us to be cautious about that we don't lose in this aspect of education until we survive COVID, if there is a time like that?
Really great question. I think the students are being very innovative about how to address some of this, because we are talking about resources. So the students, along with supervision of field placement supervisors, are engaging with some clients in person, but of course there's PPE involved in making sure that everyone is safe. Now that isn't everyone and that isn't all the time, but that is one of those things where students are given the choice. And some students are taking the opportunity and then some students are not. So I do think we have to do a little more thinking about how to really serve as many people as possible given the limitations.
Yeah, thank you for those points. Well, as you guys spoke, I heard you talk about survival by peer support and, making, because part of your education is also about socialization. Thank you for building that bridge and connecting with each other. And you talked about health and social disparities, psychosocial needs of students. We need to make sure that we are actually taking care of you and actually modeling the fact that you need to do self-care as a clinician when you graduate. We need to start now to teach you those skills. You are going to be our future frontline workers. So if you don't have those skills when you come out, it will be difficult for you to take care of yourself when you meet a lot of pressure. Thank you so much for reminding us not to forget that our students are also coming from, disadvantaged communities, and also the fact that we need to take care of them as well as other communities that we care for that are really very disadvantaged already. So I want to thank all of you for your time today, for joining us to share your experiences and your voices. Thanks a lot. I'm going to hand over to Darren, and I'm sure some of our comments actually address some of the questions already in the Q&A. Thank you. Darren, you're on.